All right. Yeah, thank you very much again. And thank you for the kind invitation to give a presentation in your lecture series. In this talk, I will be presenting on my research into cerebral small vessel disease. And specifically, I will be talking about the role of small acute brain infarcts in the origin of cerebral small vessel disease. And I'm working as a postdoc at VASCage and the Medical University of Innsbruck. And VASCage was founded in 2019 within a funding scheme of the Austrian government. But before I like to start, I would first give a brief overview on my personal background. So I have a background in psychology as well as in neuroscience. Just briefly have to change something. During my master's, I was very lucky. I had the chance to conduct 2 internships. And it's really through these internships that I got interested in the role of vascular disease in brain aging and age-related brain diseases, and also the use of MRI as research method. And so I decided to conduct my PhD at the Department of Neurology of Radboud University Medical Center in Nijmegen in the Netherlands. And it's here where I really started with my research into cerebral small vessel disease. And since 4.5 years, I'm working here in Innsbruck as postdoc at VASCage and the Medical University of Innsbruck. And here I'm continuing my research into cerebral small vessel disease. So what will I discuss today? So first, I'd like to start with a brief introduction into cerebral small vessel disease before I discuss my research in part 2 and part 3 of this presentation. And in the final part, I would like to briefly highlight some future directions and next steps. So let's get started. What is cerebral small vessel disease? So cerebral small vessel disease really is an umbrella term referring to pathological changes to the smallest blood vessels of the brain. And in terms of what do we mean with small, so there are really no clear-cut boundaries. What is defined as small, but roughly speaking, we refer those vessels in the brain that have a diameter of 1 millimeter or less. So we are not talking about the arteries, but we're talking about the arterioles, which are branches of the bigger arteries. And the arterioles are really important for regulating cerebral blood flow. And we're also talking about the capillaries, which are the tiniest blood vessels in our body. And this is also the site where exchange of oxygen takes place. And so on the left, I have included a representative image of the cerebral vasculature. And I've highlighted in bold those vessels that are affected in cerebral small vessel disease. And these include the pyoarteries that run on the surface of the brain, the cortical perforators that perfuse the cortex, the perforating arterioles that perfuse the white matter in the deeper areas of the brain, and the lenticulostriate arteries that also perfuse the deeper areas of the brain, for example, the basal ganglia. And our research into cerebral small vessel disease is quite challenging because due to the small size of the vessels, most of the vessels affected in small vessel disease can actually not be investigated during life in humans due to or with standard imaging resolutions. And so to study cerebral small vessel disease during life in humans, we have to rely on imaging markers. And one of the most well-known imaging markers of cerebral small vessel disease includes white matter hyperintensities that we can detect on FLAIR MRI scans. And just for your understanding, we're now looking at the brain from above, and I have added an MRI scan of a healthy young individual for comparison. And so when comparing these 2 MRI scans, what immediately stands out are these hyperintense signal areas in the white matter, indicating tissue alterations in the white matter. And because of their hyperintense signal, these changes have been termed white matter hyperintensities. And other common markers of cerebral small vessel disease include lacunes, which we also can detect on FLAIR MRI scans, which are fluid-filled cavities in the brain, and cerebral microbleeds, which are tiny bleedings in the brain appearing as hypointense signal areas on T2 star weighted images or susceptibility weighted images. And I think these 3 markers are really the most well-known imaging markers of small vessel disease. And we know now that these MRI markers of small vessel disease, specifically white matter hypertensities, are pretty common, especially among elderly individuals. So based on this graph, which is based on population-based studies, you can see that the prevalence of white matter hypertensities is pretty high among elderly individuals, roughly above the age of 65 years. Almost every individual will have, to some degree, some white matter hypertensities in the brain. And we know now also that these changes in the brain are not harmless. They are really associated with an increased risk of cognitive decline and dementia, and also stroke. And main risk factors of small vessel disease include age and hypertension. Now the question is, what happens at the level of the vessels that eventually leads to these MRI markers of small vessel disease? And actually, that still represents quite a big knowledge gap. But in the years before my PhD, it was increasingly suggested that perhaps small brain infarcts underlie these MRI markers of small vessel disease, underlie these brain changes. And so the question of my PhD became whether small brain infarcts are the cause of these MRI markers of small vessel disease. And using another type of MRI scan called the diffusion-weighted imaging scan, or the DWI scan, it is possible to detect acute brain infarcts in the brain. And on the DWI scan, acute brain infarcts appear as focal hyperintense areas, and we tend to call these lesions DWI positive lesions or diffusion-weighted imaging positive lesions. And there's something special about this MRI scan, which is related to biological processes that occur in the event of an acute brain infarct at the specific location of the brain infarct. And I will not discuss these processes, but because of this feature, the DWI scan only detects acute or subacute brain infarcts. So the scan only detects brain infarcts that are in the acute or subacute stage. And I would like to show that with an illustration. So the baseline scan here represents the scan on which the DWI positive lesion was first detected. And on day 35, there is still a faint hyperintense signal visible. But on day 56, the scan is completely normalized, and there's no evidence anymore that an infarct had occurred. And I like to compare this phenomenon to shooting stars, which you, of course, also only see if you really look at the right moment, and otherwise they go unnoticed. And so because of this transient detectability of these lesions, together with the often asymptomatic or silent nature of these very small lesions, many such DWI positive lesions go unnoticed. And you can imagine that that really is a challenge for research. And so to investigate whether these small brain infarcts are the cause of the white matter hypertensities, lacunes, and microbleeds, back to my research question, you really have to scan individuals very frequently, preferably every 2 to 4 weeks, to not miss any lesion. And so that's exactly what we did. We designed the RUN-DMC intent study, in which individuals with small vessel disease underwent every month an MRI scan for 10 months in a row. And the main objective of the study was to determine the proportion of small vessel disease progression, including the progression of white matter hypertensities, lacunes, and microbleeds that could be explained by incidental DWI positive lesions. And for this study, individuals were retrieved from the ongoing RUN-DMC study, which is a prospective cohort study on the causes and consequences of small vessel disease, with baseline in 2006 and frequent follow-ups every 4 to 5 years. And main inclusion criteria for the RUN-DMC intent study was participation in the RUN-DMC 2006 and 2015 waves, and having had progression of white matter hypertensities between these 2 time points. And main exclusion criteria for the RUN-DMC intent study were having another or an additional cause of acute ischemia, such as a carotid artery stenosis of more than 50% or atrial fibrillation. Also, patients with an intracranial hemorrhage other than a microbleed were excluded, and patients with dementia or Parkinson's disease were excluded. And as I said, these individuals underwent monthly an MRI scan for 10 consecutive months. And the 3 Tesla imaging protocol included multi-cell high-resolution diffusion-weighted imaging to detect the incidental DDR-positive lesions, 3D-T1 and FLAIR to detect the white matter hypertensities and lacunes, and a multi-echo gradient echo sequence, which we use to generate susceptibility-weighted images to detect the microbleeds. And the incidental DDR-positive lesions, lacunes, and microbleeds were all rated manually, and we used an automated method to delineate the white matter hypertensities. And in addition to each visit, participants underwent standardized questionnaires and cognitive tests, and they were asked for any medical events in between visits. So let's move on to the results. In total, 54 individuals with small vessel disease participated, and the median baseline age was 69 years, and 63% was male, and 54% had a VASCage score of 2 or higher, which means that nearly half of the individuals had moderate to severe white matter hypertensities. And in total, we collected 472 DWI scans, and we detected 39 incidental DW-positive lesions in 9 different participants. And all these incidental DW-positive lesions were clinically silent. And you can see here a couple of examples of the DW-positive lesions that we detected in the study. And now, because of this monthly serial imaging design, we could really carefully follow these lesions over time and assess the evolution of these lesions into MRI markers of small vessel disease. And I would like to show that with a short video. So in this video, you will see the 10 MRI scans of one individual from the study. And the above row shows the DWI scans, which we use to detect the acute brain infarcts. And the other 2 MRI scans, the other 2 rows, demonstrate the evolution of these lesions into MRI markers of small vessel disease. And so this case had over time 6 different DW-positive lesions, and you will see in the video the evolution of these lesions. So when looking at the total proportion of small vessel disease progression that could be explained by the incidental DW-positive lesions, we observed that white matter hypertensities overall progressed at a median rate of 0.027 milliliter per month. However, only 2 DW-positive lesions in 2 different participants evolved into a white matter hypertensities. We detected also 5 incident lacunes or incident small cavities, out of which 4 were preceded by a DW-positive lesion. And we detected 10 incident microbleeds, out of which 3 were preceded by a DW-positive lesion at the corresponding lesion location. So based on these results, we concluded that DW-positive lesions contribute to progression of small vessel disease, but they are not the most important cause of white matter hypertensity volume increase. And in addition to these findings, we had another interesting finding. Because the majority of the incidental DW-positive lesions were not located in subcortical regions, but were located in the cortex, and they were also smaller than 5 millimeter in largest diameter. And with that, they fulfilled the criteria for acute or recent cortical microinfarcts. And so as a next step, we wanted to investigate the evolution of these acute cortical microinfarcts. In total, we detected 21 acute cortical microinfarcts in 7 different participants. And for 20 out of the 21 acute cortical microinfarcts, we also had follow-up MRI available. And whereas almost all acute cortical microinfarcts in their acute phase were accompanied by a hypointense signal on T1 and or a hyperintense signal on flare, none of these acute cortical microinfarcts evolved into a chronically visible lesion on T1 or flare. And so there was no evidence anymore that an infarct had occurred. So to sum up this part, in the RAN-DMC intense study, we saw overall a prevalence of incidental DDR positive lesions of 17%. And we saw that incidental DDR positive lesions contribute to small vessel disease progression, but they only explain a small proportion of the total white matter hypertensive volume increased. In contrast, incidental DDR positive lesions explain or are the main cause of incident lacunes and small cavities, and also cause some microbleeds. And finally, we saw that small cortical DDR positive lesions never evolved into a chronically visible lesion on follow-up T1 and flare. And so now I would like to take you to my next study, which I conducted together with Susanne van Velu at Massachusetts General Hospital in Boston. So up to now, I have always said that these DDR positive lesions reflect acute brain infarcts. However, by that time, there was actually no proof of this. And so I became really interested in investigating the underlying substrate, so to say, of these lesions. And we decided to set up a combined MRI histopathology validation study to investigate the histopathology of these DDR positive lesions. And for this, we had formalin-fixed brain tissue available of 12 cases with cerebral amyloid angiopathy, or CAA, and 3 controls. And cerebral amyloid angiopathy is the second commonest form of small vessel disease, and it's marked by the deposition of the peptide A-beta in the walls of cortical perforators and pyoarteries. And cerebral amyloid angiopathy is a major cause of hemorrhages, including large lobar intracerebral hemorrhage and microbleeds. And cerebral amyloid angiopathy is also associated with a high burden of cortical cerebral microinfarcts. And so we scanned the brain tissue that we had overnight using an 8-hour diffusion imaging protocol. And on the DRS scans, we detected 130 DDR positive lesions in 10 out of the 12 cases with CAA, but in none of the controls. And in terms of topographic distribution in the brain, we observed that these DDR positive lesions appeared in similar locations as older microinfarcts, which had already been identified in the context of a prior study. And on histopathology, we found evidence that these DDR positive lesions reflect acute brain infarcts, as evidenced by the presence of eosinophilic neurons, which are shrunken hypoxic neurons, and the presence of only few reactive astrocytes in the lesion periphery. And together, these pathological features are really the hallmark of acute ischemic injury. And so based on this study, we could provide the first evidence that these DDR positive lesions reflect acute microinfarcts. And in the last part of the presentation, I would like to discuss or highlight a few future directions and next steps. So incidental DDR positive lesions are now increasingly studied and recognized. And I've provided here an overview of different studies conducted in different types of populations. And all these studies have reported a baseline prevalence of incidental DDR positive lesions, so a prevalence based on a single time point. And we can, of course, not immediately compare all these numbers because studies are different. For instance, studies have different MRI protocols, which also affects the detection of DDR positive lesions. But overall, we can say that the prevalence of these incidental DDR positive lesions is relatively low in the general elderly population, about 1 to 2%. But it's increased in patients with more severe small vessel disease, suggesting that these are really a marker, that these lesions are really a marker of small vessel disease. And in our latest study, we found a prevalence of 22% in patients with CADASIL, which is a genetic form of small vessel disease, and a prevalence of incidental DDR positive lesions of 56 in patients with probable cerebral amyloid angiopathy. So 1 out of 2 individuals had 1 or more incidental DDR positive lesions. And these latter findings, these latter observations in CAA will soon be validated in an independent multicenter cohort called the HIFI-CAA study, which is led by the Institute for Stroke and Dementia Research in Munich. And for this study, we're now rating the DWI scans. And the study will provide us more insights into the prevalence of DW positive lesions in CAA, and specifically also the progression of these lesions over time, as the HIFI-CAA is also a serial monthly MRI study, similar to the RUN-DMC intent study. And incidental DW positive lesions are not only detected in research settings, but also in the clinical setting, especially also in patients with intracerebral hemorrhage. And accumulating data from a meta-analysis as well as from a very recent study indicates that the prevalence of incidental DW positive lesions in patients with intracerebral hemorrhage is about 20 to 25%. And this really may pose a challenge for clinicians who have to weigh the future risks of ischemic and hemorrhagic events when deciding on treatment strategies after ICH, including also the use or the avoidance of antithrombotics. And because of this transient detectability of the incidental DW positive lesions that I discussed in the beginning, you can imagine that these DW positive lesions are not a one-time event. And this study has estimated that the detection of even a single DW positive lesion suggests an annual incidence of hundreds of new microinfarcts in the brain. And you can imagine that the cumulative effects of these lesions over time really pose or increase the risk of developing cognitive impairment and dementia. And so to better understand the clinical relevance of these lesions, I'm now establishing, together with researchers from the National University of Singapore and Radboud UMC in Nijmegen, the diffusion-weighted imaging positive lesion consortium, abbreviated as DIAGNOSE. And the goal is really to conduct pooled analysis on existing data to increase sample size, to investigate the prevalence and incidence of these lesions in different types of populations, to assess the risk factors of these lesions, and to investigate the association between these lesions and future clinical outcomes, including stroke, dementia, and death. And up to now, 14 studies from 7 different countries are already joining the initiative. And together, these studies have roughly 6,000 baseline DWI scans. And I really hope that I can present first results next year. And the final future direction that I find very interesting, that I would briefly like to highlight, is that I think that these incidental DW positive lesions and also incident infarcts in general really provide an opportunity for clinical trials in the sense of improving trial efficiency when these imaging markers are included in the trial outcome. There's compelling evidence that incident infarcts are much more common than recurrent stroke. And I would briefly like to highlight this recent study from Paris. The study included patients with ischemic stroke due to small vessel disease, and patients underwent MRI at 6 months. And at 6 months, 6 patients had had a recurrent stroke, and an additional 15% of the patients had incident infarcts on MRI. And so they estimated that for a hypothetical trial or intervention based on MRI-proven incident ischemia, which also includes these asymptomatic infarcts, roughly 6 times less patients would be required for such a trial compared to a trial based on recurrent stroke only. And I think this is a very interesting approach, and this is more and more adopted, especially in phase 2 trials, and it was also adopted by the Pacific Stroke trial sponsored by Bayer. So coming to an overall conclusion, I've been talking about incidental DW-positive lesions in the context of cerebral small vessel disease. And with the Run-DMC Intent study, we aim to investigate to what extent these incidental DW-positive lesions contribute to progression of MRI markers of small vessel disease. And we saw that these lesions contribute to small vessel disease progression, but they were not the most important cause of the white matter hypertensive volume increase. But in contrast, we observed that these incidental DW-positive lesions are the most important cause for the acutes and also cause some microbleeds. And with my study, I could provide evidence that incidental DW-positive lesions reflect acute microinfarcts. And incidental DW-positive lesions are now increasingly studied, and recently they were termed as an emerging marker of small vessel disease. Their cross-sectional prevalence is relatively low in the general elderly population, about 1 to 2%, but it's increased in patients with more severe small vessel disease, such as patients with probable CAA. And to better understand the clinical relevance and also the risk factors of these lesions, I think it's very important now that we start to investigate these lesions in larger data sets. So I would like to thank all my collaborators and thank you again for inviting me to give this lecture, and thank you all for your attention.